Hello and welcome to another Top Doctors online interview with one of our leading specialists. Today, we are so honoured to be joined by Dr. Richard Shaffer, a highly esteemed London-based radiation oncologist and specialist in radiotherapy for non-cancerous conditions. Dr. Shaffer, thank you so much for taking the time to speak to us today. Would you like to introduce yourself?
Sure. My name's Dr. Richard Shaffer. As you said, I'm a radiation oncologist. What that means is that I use radiotherapy to treat cancer. We use that in very high doses, but I also use radiotherapy in lower doses to treat non-cancer conditions or benign conditions. And today we're going to talk about one of those conditions and how we treat that with radiotherapy.
Absolutely. And as you mentioned, today we're going to talk about plantar fasciitis. I hope I'm saying that okay. It's one of those tricky ones. So very basic question to start off with. What is plantar fasciitis?
So plantar fasciitis is a condition where people get heel pain. And the reason why they get it is because of strain, overuse of the plantar fascia. And the plantar fascia is the layer underneath the skin on the heel that supports the arch of your foot. And so when you overdo it with that, so for instance, people who do too much exercise, people who use bad shoes, which put strain on the wrong parts of your foot, people who are overweight. There are various reasons why you can get strain of the plantar fascia. In fact, I actually had it for a couple of years, and we've got twins, and I was carrying both of them on my shoulders. And I came down a step, and I just sort of twanged my foot, and I had plantar fasciitis as a result for a couple of years in my left foot. So I've got experience of having this condition. It was quite painful, actually. Anyway, so plantar fascia, that's what it is, strain, and you get pain in your heel, and that obviously can cause problems with walking, running, and sometimes even standing if it gets quite bad. So yeah, that's what the condition is.
Super, very good. So we have an actual expert in the condition then in every sense. Perfect. So the next question was, what is happening inside the foot when the condition is present? I think you've kind of touched on that. Is there anything else that happens in the other, in the surrounding part of the foot? How does it affect other parts?
Well, I mean, it's important to say that as a result of that strain, you get degeneration. So a bit of breakdown, some tearing, and probably some inflammation as well, although not always. And so those are the processes really that are causing the pain. But indirectly, what happens is you stop stepping on that part of your foot. So if you stop stepping on your heel, then it tends to be the other parts of the foot that take the strain, or the other foot. So you start to get secondary effects as well in the way that you're walking or what part of the foot that you're walking on. But that sort of primary area, the heel, is where the proper process happens.
Absolutely. And what is the cause, one of the main causes of the condition?
So as I say, there are various reasons why you might put more strain on your foot. So really it's to do with having too much pressure on your foot. So when I was carrying my twins, I had a lot of weight on my shoulders. And that's why when I took that step, it really just put too much strain immediately. Sometimes people get it from when they don't do much exercise and they do a massive run just out of the blue. Often that happens to people like myself in middle age, who really have stopped doing exercise, and then suddenly they'll go and play, an hour or two game of squash or something. Poor footwear can put strain on different parts of the foot. So people who wear heels a lot, that can cause plantar fasciitis. And interestingly, sorry, you're still there.
Sorry, yes.
You froze. And interestingly, this condition actually happens in about 10% of the population. So 1 in 10 people actually get this in their lifetime. I mean, this is a very, very common condition. And for most people, by the time you take the strain off the foot and do various conservative things, which I'll go through in a moment, actually that can get rid of the condition. So 80% of people respond to those conservative measures, as we call it. So what would that mean? So taking the strain off your foot means resting. And really that needs to be full rest. Sometimes people do stretching exercises. So, there are various videos online that can show you how to do those exercises, very straightforward. Sometimes people go to a physiotherapist to do those, but in my view, that's not necessary, really. You can do those yourself. So resting, stretching. Sometimes people find that icing can be helpful. So putting, your foot in sort of ice water or with an ice pack. Sometimes people find that relieves things. Clearly changing footwear can be helpful. So people can wear arch supports and get yourself out of heels as well into more comfortable shoes. Sometimes people need specialized orthotics, although in my view, most of the time that isn't going to give more of a result over just getting sort of over-the-counter orthotics. So those are really the sort of conservative treatments. When we move on a little bit into the more medical treatments, sometimes people start with steroid injections. And that's something that people have tried a lot in the past. So a steroid injection into the area. The thing is, they can sometimes give you relief. They're very painful, actually. And for most people, they'll give you a relief for a few weeks, and it comes back. So this is not really, for the vast majority of people, a permanent solution.
Yeah.
So that's the steroid injections. The next one to talk about is called PRP. So platelet-reduced plasma. And that's a sort of fancy type of injection. And you take your plasma and you sort of spin it in a centrifuge to get a particular solution you can inject back in. And there is some evidence showing that that can be effective, but it takes roughly 6 months to be more effective than placebo. So I have to say, it's not something, in my view, that's very useful for most people. The next thing to think about is extracorporeal shockwave treatment. So often people just call it shockwave treatment, and that's available all over the place. So your GP might do it, your physio might do it, sports and exercise, foot and ankle, all sorts of people can do it. And for some people that can be effective. Again, I saw someone yesterday actually said, I had shockwave treatment. It was terribly painful, he said. So for some people it can be quite tolerable. For some people it's very, very painful. And in fact, when they started doing it, they actually gave local anesthetic before they did it because it was so painful. But looking at the evidence, the type of shockwave treatment they used were very variable, and the outcome measures they used were very variable. So it's difficult to know really overall whether it works. It's a little controversial, but as I say, for some people it can be effective. Going sort of up the sort of invasiveness in terms of treatments, and we will come to radiotherapy, which of course what I want to talk about afterwards, but you then come to surgery, and in my view that's really a last resort. It's invasive, often it requires an anesthetic, and generally it requires quite a lot of recuperation. So being off your foot in a boot. Obviously there are risks of infection and bleeding. Sometimes things just go wrong. So I have to say, in my view, surgery, although it can be very effective, is just not something I would go for until I've really exhausted all the other treatments. So that's the sort of landscape of the treatments that a lot of people know about. And obviously we can come on to radiotherapy afterwards.
Perfect. Super. So I think one question that's come up just hearing about all these different treatments is, how is the best treatment decided? Is it related perhaps to the symptoms that a patient presents, or is it completely the patient's decision to pick what they think is best?
I think that's a really good question. So, I mean, in my view, for the first sort of 3 or even up to 6 months, really persevere with the conservative treatment. You don't need medical treatments for the first 3 months. So make sure you persevere, rest as much as you can, change your footwear, maybe get orthotics, do the stretching exercises. Just see if you can get rid of it at that time, because 80% of people will find it gets better with those things. And of course, why waste your time, your money, and potential side effects getting medical treatments where you can potentially manage it yourself? So that would be my view in terms of what you choose to start with. Now then, in terms of what other treatment people have, I think that just depends where you land up in terms of what your GP thinks, maybe, whether your GP knows about a particular physio or a particular foot and ankle surgeon or whatever, or a talk they went to recently. I think that tends to be how these treatments are chosen. And I think that often it's to do with availability, it might be to do with cost, and often it's about health beliefs. So I think that, these days, patients are trying to look for the best treatment themselves. And often patients will find different treatments on the internet. They might hear from other people. Obviously, it might be their GP that tells them, but now there are sort of more ways that they can find information. So I think, every patient's journey is different to how they find their particular treatment. But as I say, I think actually the main thing depends on what their GP thinks or what they've heard about recently or what they know about.
Of course, absolutely. Let's get on to radiotherapy then as a treatment, something that you specialize in. So, how is radiotherapy used to treat this condition?
So, I mean, I'll just go back over
Of
radiotherapy
course.
again. Let's just talk a little bit about what it is.
Yeah.
I mean, radiotherapy is the use of radiation. So it tends to be X-rays, or there is slightly different types of radiation as well that we use in high doses to treat cancer. And the reason why we use it in cancer is because it stops stuff growing, and cancer is something that grows uncontrollably.
Mhm.
Now, we use a sort of intermediate, sort of half dose in other benign things that grow uncontrollably. So things like keloid scars, Dupuytren's disease of the hand, where you get nodules and it causes some bending of the fingers. And then we go down a level to sort of a 10th to the 20th of the dose that we use for cancer. I mean, like, we're talking a tiny dose. And
Mhm.
that we really use for inflammatory and degenerative conditions. And we use it because it works really well as an anti-inflammatory treatment. And so for plantar fasciitis, that's really why we're using it as an anti-inflammatory, and it reduces pain as an anti-inflammatory, but perhaps in some other sort of ways as well.
Mhm.
And the reason why radiotherapy is so good is two reasons. Number one, it's very effective. So it will help 80 to 85% of people with plantar fasciitis. The second thing is that it doesn't have any side effects. And so basically, I'll just take you through what would happen. You know,
Mhm.
I'll see you generally in clinic, although sometimes I could do that over Zoom or Teams or whatever, and assess how bad the pain is. You know, when you get the pain, just make sure that we think this is actually plantar fasciitis. Occasionally, I would need to do some investigation, so maybe some imaging with ultrasound or MRI, but I have to say, generally, that's just not necessary.
Mhm.
So I'll assess how things are. Ideally, if I'm seeing you in clinic, I would really always want to be examining the foot, seeing how you walk,
Mhm.
making sure the pain's in an area that's consistent with the diagnosis. Once we do that, then I would tell you about the treatment, and then sign a consent form. The next stage in the treatment is you would have a CT scan, and this is not to look for anything new. It's not a diagnostic CT scan. It's just so that we can direct the radiation towards the right part of
Okay.
the heel. Um, and then the treatment, you're literally lying on your back on a hard couch, machine moves around you, invisible radiation comes out at the end of the machine, and the whole treatment takes about 10 minutes a day as an outpatient. It's not painful, there's no needles, doesn't make you drowsy or dizzy, doesn't cause any burning or stinging or anything like that. I
Yeah.
mean, literally, it's completely painless. Takes 10 minutes a day. We will do that twice a week for 3 weeks. So 6 treatments in all. So something like Monday, Thursday, Monday, Thursday, Monday, Thursday. I would then see you at 3 months after that. If the pain has got better, and about 50% of people will find the pain is substantially better, so that actually that's enough,
Mhm.
then that may well be it. But about 50% of people do require a further 6 treatments over 3 weeks.
Mhm.
And so, often that would be the second course of treatment. Then I would see you again at 3 months. And for most people, that's it. So that's where that 80 to 85% of people comes in that get benefit from this treatment. And as I say, no side effects. I always say to people, well, there is a chance that the pain might temporarily get worse. So that
Mhm.
can happen. There's a chance that the skin can become a little bit red and sore, although I have to say, I just don't see that. I'm just overcautious in the way that I talk about these things. There is one thing that's really important to say, and that is any radiation, as well as being used to treat cancer, has a very, very small risk of causing cancer, a type of skin cancer, in
Mhm.
the area that we treat. So if I'm treating the foot, that would be, where the risk of skin cancer comes. Now, for a 45-year-old, I normally quote a 1 in 1,000 lifetime risk. The older you get, the less the risk is. So if you're 60, it's probably about half that risk, so 1 in 2,000 lifetime risk. So, the
Okay.
message is it's not a zero risk, but it's very, very small. So that would
Mm.
be an important thing. Of course, if you're 25, then it's a bit of a different conversation because that would be an increased risk. And the reason is because you've got more years to live and therefore more years to form a cancer and
Mm.
therefore an increased risk. So, these conversations, it's a balance really. So we talk about, well, what's the benefit of the treatment, what's the risks of the treatment, and then we talk about whether I would advise it and whether you feel comfortable with it, and then we decide whether to go ahead with the treatment.
Perfect. It's very insightful. Thank you for all that. I suppose the natural question to go on from that is who is then the ideal candidate for radiotherapy treatment?
So, well, that's interesting because the people I've treated so far have tended to be those where they're really just desperate. They've tried everything else and they come to me. And interestingly, radiotherapy is effective. I've treated people who've had it. My last patient I treated had it for 12 years. And she said it was transformative. When she came, she really couldn't walk properly. She just found it was just impinging on her life. She described that, the pain as being either moderate or severe. And then I saw it 3 months after the first course of treatment, and the radiotherapy had really helped at that point. But she said, look, it's not helped quite enough. Let's go on with the second course of treatments. Gave her the second course, and it got better. So she was able to walk for miles at that point. I then saw her a year after the second treatment, and really the pain had pretty well completely resolved. So, that was quite interesting, looking at someone who's had it for many, many years, and it really helped them. So that's one sort of group of people that I definitely do treat. But I have to say, the people that are going to respond the best are those who come to me, really where they tried conservative treatment already for at least 3 months, but it's within a year or two of getting the pain. And those are the people who really have the best chance of responding. So, it depends what you mean by ideal. I mean, the people who are going to respond the best are the people who come earlier, but the people who really come to me because they're sort of desperate and don't have anything else, those are also people who are very, very grateful when things go well, and those are the people also where it works, who it's very gratifying really to treat them.
Absolutely. And I suppose the last question I have regarding this is, well, when should you see a specialist? I presume that's as soon as you can recognize the pain. But also in that recovery time, or the time after receiving treatment, is there anything patients should avoid doing to get optimal results?
So just taking your questions one at a time. So when should you see a specialist? I mean, my view is that really you should manage it yourself for the first few months. So, there's plenty of information online about resting, stretching, icing, changing footwear, and so on. So I think, the time to see a specialist is when you've tried those things and it's not worked. So, that's really the point where you need to see a specialist. In terms of what you do in the sort of waiting period after radiotherapy, when you're waiting for things to kick in, because of course, it does take a number of months to work, then really you should just be continuing to do those things. So, radiotherapy is one component of your care, but you still should be wearing good footwear, losing weight potentially, making sure you're not doing the wrong sort of exercise. So impact exercise in particular is something you should avoid. And all those sort of self-care things, you should be continuing to do those things, because radiotherapy will work best when you're managing all those things at the same time.
Perfect, super. And I suppose to finish up, can plantar fasciitis return? Can it reoccur if not managed correctly?
Yeah, so it can recur. I would say two things. One reason why it can recur is because you're going back to putting strain on your plantar fascia. And so, if I sort it out with radiotherapy, and then you go back to wearing heels, doing too much exercise, whatever it might be, then absolutely you can return. Or it may well just not be your fault. You might be very prone because of the configuration of your foot, your arch is too high, too low, whatever you've got, tightness in your muscles, whatever it might be. So there are various reasons why it might recur. And I am able to retreat people if necessary. So that's certainly something we can do. But at that point also, I would send someone to have analysis of their gait, so the way that they walk, and see just whether there is something else that needs to be done, rather than just sort of off-the-shelf sort of orthotics. Then it would be worth assessing that as well.
Perfect, super. I'm not sure if I've missed anything in the questions. You spoke perfectly. I think we've covered everything. If there's anything else you'd like to add, now's the time.
No, I think that's it.
Perfect.
So thank you for the opportunity.
Thank you so much for being here with us. We really, really appreciate it. And of course, to anyone watching or listening, if you would like to book a consultation with Dr. Shaffer or any of our specialists, experts, you can do so by visiting the Top Doctors website today. Dr. Shaffer, thank you again so much for joining us.
And thank you.